our each talk from our presenters. We're going to open up the floor. We're going to hear from the participants here about your context, your situation, what you're doing about improving care for patients on ventilators in your hospital. So please, we encourage you to participate. So let me introduce Let me introduce our trainers for this workshop. First, here on my left, we have Dr. Thomas Sandora. He's an associate professor of pediatrics at Harvard Medical School and the medical director of infection prevention and control at Boston Children's Hospital. And to his left, we have Dr. Benjamin Park, who's the chief of the International Infection Control Program, the Division of Healthcare Quality Promotion at the U.S. Centers for Disease Control and Prevention. Now, before we begin, I'd like just to have a little bit of information about who's in the audience today. So maybe we can just have a show of hands about the country that you're coming from, just so we understand the context of the participants. So if you're from Vietnam, could you raise your hand? Okay, thank you. Thailand? Indonesia? Malaysia? Singapore? Any other country I did not?
Bangladesh.
Sorry?
Bangladesh.
Bangladesh? Brunei? Thank you. Yes?
Australia.
Australia, okay. And how about the role you have in your hospitals? How many of you are working in the infection control departments? Okay, majority, yeah. How about working in the intensive care unit? Okay, how about doctors? How many are doctors? Nurses? Okay. Anything else? Okay, great. All right, so I think that's all for introductions. So why don't we ask Dr. Park to give his first presentation on the epidemiology, scope of the problem, and basic concepts and definitions.
Good morning, everyone. Good morning. Okay, one more time. Good morning, everyone. Good morning. Oh, much better. Okay, my name is Benjamin Park. I'm from the CDC in Atlanta, USA. And maybe some of you are wondering, but he looks Asian. How can he be American? But I was born in the USA. My family's Korean, so that's why I look like this. I know that I'm not a soap opera star, I promise you. I'm not a K-pop star either, but I am a doctor and an epidemiologist as well. So I'm the head of a group at CDC that is called the International Infection Control Program. And we have actually a number of people here from CDC at this conference, so we're very happy to be here. It's amazing to see all of you. It's amazing to see all of you that are interested in infection control. And just I want to say a few words about who I am and what we do at CDC. So again, I'm a physician by training. I started off doing public health. I've been doing public health now for 17 years at CDC. Oh, thank you very much. Doing outbreaks, working on public health, doing surveillance, all in the scope of both domestic and international work. I've been doing healthcare-associated outbreaks and conditions since then. And at CDC, we have a group called the Division of Healthcare Quality Promotion. And that's the group at CDC that focuses on healthcare-associated infections. And this group is the same group that works on NHSN. Maybe you've heard of NHSN, National Healthcare Safety Network. And we also work on outbreaks, multi-drug resistant organisms. We work on surveillance and many other different types of things, point prevalence surveys. And most of this work is done on the domestic side to support the USA on our domestic agenda. And then we have a group of us, actually about 25 of us, that work on the international side. And we help to support countries like Vietnam, also Thailand, Cambodia, some other countries in this region in addition to other countries and other regions, for improving infection control, reducing healthcare-associated infections, and also antibiotic resistance. So this conference is a great opportunity, we think, to exchange ideas, to share how we're doing in our different countries, and to really, I think, be an exchange of information so we can learn from each other and build networks and build community. Because honestly, I don't know how many of you know each other, but probably you have a lot in common. You probably have many of the same job responsibilities, many of the same challenges, both from a work-related standpoint and also, I think, from an advocacy standpoint. I think many of us talk about how important infection control is, but here, when we're together as a community, I think everyone understands that. Sometimes you're in your hospital talking about how important infection control is, and the surgeons don't listen to you. But here, we all understand. So you can share your ideas here. Please share your experiences. This, I think, as Todd mentions, is a time for us to learn from one another, okay? This is not a time, I think, to receive a lot of information by lecture, but really to share our experiences and to think about how we can together improve this area in the region, this area of infection control. So I'm going to talk a little bit about surveillance, and I'm going to talk a little bit about VAE in particular. And a lot of what I'm going to say is relevant, especially to the United States, because that's where CDC is, and that's where a lot of these definitions have started, was the United States. And what I want you to do is think about how this experience translates to your own setting and what you can take from it to your own setting. The important thing, I think, I'm going to say the most important thing I'm going to say up front, which is, and I'm going to reinforce it during the talk, is that surveillance in the United States is meant to be surveillance in the United States, okay? We did not develop surveillance in the United States with the intention that it should be done everywhere in the world, okay? That was not the intention of developing an HSN. An HSN was developed for the United States and for the US context. Now, many other countries will use NHSN, will use the definitions from NHSN. That's okay, it's up to the country to decide. But by no means do we think that NHSN is the gold standard and it should be used across the world, okay? So remember, when you think about surveillance in your context, you have to think about what is relevant, what is important, and what will be effective in your own situation. Getting back to the principles of surveillance, and we're going to talk about that in a little bit. Okay. Next slide. Okay, so the objectives of, sorry. Okay, there's a delay. Okay, objectives of this are to understand the purpose of surveillance for HAIs, healthcare-associated infections, review the rationale for changing the approach, again, in NHSN from ventilator-associated pneumonia to ventilator-associated event, and describe the surveillance definition algorithm for VAE. I think Dr. Tom is going to talk more about prevention of VAE. He's going to talk more about prevention of pneumonia, talk about the bundles, as well as talk about pediatrics. Okay. All right, so before I begin, I want to get a sense from you all about what you're currently doing around hospital pneumonia surveillance. Because I think that's why we're all here, is because everyone here is interested in pneumonia. So the first, I want to ask you to raise your hand if you're doing any type of surveillance for pneumonia. It can be ventilator-associated or non-ventilator associated. Any kind of pneumonia surveillance, raise your hand if you're doing it in your hospital. Okay. How many of you want to do pneumonia surveillance? No, you're not doing it right now, but you want to do it. But you don't know quite where to start. Okay. A few. You can raise your hand higher. Come on, raise it high, raise it high. There you go. Okay, there you go. Oh, more people. Okay. How many of you don't want to do it? You just want to learn something today. Yeah, okay, good. We have someone honest. And maybe that's the right answer, actually. We don't know. Okay. Okay. For those of you that raise your hand first, so these are the people who are doing pneumonia surveillance. How many of you are doing ventilator-associated pneumonia surveillance, or VAE, or something like that? Something in the ICU. few. Okay. How many of you are doing pneumonia surveillance that's not ventilator pneumonia? So both. You're doing both in your hospital? Okay. Now, and you also? Okay. Now I'm going to ask one of you to share how it's going. I want to hear your experience. This is before I start because I want to hear your experience. How is it to do ventilator-associated pneumonia surveillance? The questions are specifically, is it difficult to do? Does it take a lot of time to do it? Is it confusing? And do you find that it's at any value for your hospital? Are you getting value out of it, and what kind of value do you get out of it? So who's going to start? Who's doing surveillance? Raise your hand. I'm going to choose someone if you don't volunteer. Okay.
Because we are still.
Introduce yourself and where you're
Okay, I am Cahyarini from Persahabatan Hospital in Jakarta, Indonesia. Yes, we do surveillance of VIP surveillance in ICU setting. For last 3 years. So who responsible for VIP surveillance actually is my friend beside me. So maybe she could.
Thank you for the opportunity. My name is Ezi Barnita. I'm a pediatrician and actively in surveillance control, in infection control. So what we do in Indonesia, we build the system, the bundles of the VIP, and then we do an active surveillance by our IPCNs daily. And after we have a case that we are suspected as a VIP, we will make a small team to decide whether it is truly a VIP or not. But mostly the challenge that we meet in the field that the doctor, the physicians tend to refuse that we label this patient as a VIP because this is also due to the value of our hospital. The rank of our hospital is also determined by the number of highs that we are reporting. So that's actually the problem that we face right now.
Okay. Thank you. Thank you. So very interesting, and I hear that a lot. So thank you for sharing. You're doing VAP surveillance. From what I heard you say, one of the challenges is that because you have some type of reporting, and there's probably some type of punishment maybe that comes with reporting, comes with high reports, that the clinicians often do not they will sometimes challenge the definition because of this. Okay, good. All right, who's next? Who else wants to share? Yeah.
Yeah, good morning, everybody. My name is Tong. I'm working in the Department of Infection Control at Ho Chi Minh City University Medical Center for 10 years. And when doing the VAB or VA surveillance in our hospital and in other hospitals in general in Vietnam, with I think the most important challenge that we are facing is the definition, the difference between the definition of who are doing the surveillance and who are doing in the clinical aspect. We don't have the same goal and also the same criteria for a case. What is a case? The second one, maybe in our own situation, because I'm working mostly in microbiology. I don't know what is a ventilator, what is exactly a PIP FiO2 or something like that. And what I can do is to read the definition from the CDC website, and after that we follow the event on the clinical situation, and we found something, you know, different. Well, because it's not the same in the document and the thing in reality. We don't understand many cases. Yes.
Okay. Yeah,
Okay.
that's good. So the definition is somewhat complicated and does require training. And thank you for sharing from Vietnam. I'm going to ask one more person to share, maybe someone from Thailand. Who's from Thailand who wants to share?
Hello, I'm from Thailand. I can speak English a little, but in my hospital, I'm web surveillance. Yeah. The definition I use CDC definition of web and non-web. I'm ICN nurse. When I go to division ward, we surveillance in the ICU ward for web. In my hospital, I have many ICU. Yes, we surveillance web every ICU, and non-ICU we have many people to use ventilator, you know, and we surveillance other.
So let me ask you a question. What do you use the data for? How do you use, once you collect the data, what do you do with the data?
Every day, daily, we go to the board and to look many people to use ventilator, and they have sign of infection in respiratory, and another of chest X-ray is changed. Yes, and we collaboration with the doctor infectious.
Do you use the data for any kind of prevention efforts?
Definition of web.
Do you, when you collect the data for VAP, do you use the data to help improve your prevention efforts, or to, for example, say where you need to have more energy to put on prevention, or what do you use the data for?
The reports?
Yeah.
Yes. Every weekly and month. Every month.
Every week and every month.
Yes.
Okay.
To
All
the
right.
team. Yeah.
To the team. Okay. All right. Okay. Thanks. So we heard some good experiences there about VAP and how people use VAP. We heard sometimes it's challenging because people might have different interpretations of the definition, or because there's a debate sometimes between surveillance and clinicians about whether or not it's a real VAP or a surveillance VAP. And then there's some question about how to use the data, you know, through reports and things like that. So the first thing I'm going to talk about is HAIs, healthcare-associated infections, and how surveillance is a piece of that. Obviously, we know surveillance is used for many things other than HAIs, but we're here because of HAIs. So HAIs, I think we all understand, are a significant cause of morbidity and mortality. And it's even more important, HAIs are even more important in low and middle income countries, because the data show that they can be 2, 3, 4, 5, or even more times more prevalent in low resource settings than in high resource settings. Why do you think that's the case? Well, I think especially in Southeast Asia, and we were talking about this earlier today, especially in Southeast Asia, I think where there is a lot of very complicated medical care that's now being provided. You have a pool of patients at risk that is growing and growing. For example, you have more people that are in the ICU. You have things like dialysis. You have surgeries. more and more people have access to high-tech medical care, right? And that's a good thing. That's a good thing. It's good for our patients. But at the same time, in many places, the safeguards, the safety is not, I think, as advanced as some of the care, as some of the clinical care. And so when you have a lot of people that are at risk, but you don't have the safety that's necessarily involved, that's needed to prevent those infections, then you can have high rates of infection. So that's oftentimes what we see. And maybe that's the case in your hospitals, I don't know. But a lot of times what we'll see is that the staffing for infection control is understaffed. You have few infection control nurses, few ID docs, and I see people nodding their head, yes, that's the case in my hospital, where we don't have the same number of staff as you might have in Europe or the United States, specifically for infection control. So if you don't have enough people to do it, then obviously you can't expect there to be a better outcome. So what are some of the drivers of high burden of HAIs? You talked about this before, but environmental cleaning is one issue, poor infrastructure, insufficient equipment, understaffing, overcrowding, limited knowledge and application of infection control, inappropriate use of antibiotics, inappropriate use of invasive devices like central lines, like ventilators, and then a lack of national or local policies and guidelines. Next, please. Okay, why do we do HAI surveillance? Okay, I think this gets back to one of the central questions about before you start to decide what kind of surveillance you want to do, before you decide if you want to do VAP surveillance or VAE surveillance or something else, you have to first answer the question, why am I doing surveillance in the first place? Because if you can't answer that question, then you'll never be able to come up with the answer to what kind of surveillance you should be doing. Because remember, surveillance is done for all different kinds of reasons. Sometimes you want to do surveillance because you want to measure the burden of disease. Sometimes you want to do it because you want to do an active prevention program. Sometimes you want to track trends or look at geographic distribution. So you have to answer these questions about why you're doing surveillance first in the first place before you figure out what kind of surveillance is the best kind to answer those questions. So remember, a lot of times I think we do surveillance because someone tells us that we need to do surveillance. But the first, I see people laughing because probably maybe that's your experience in your hospital. Someone says, maybe higher up, they say, okay, do surveillance and report back to me. Tell me what you find. And I know it's not easy to say, go to the hospital, head of the hospital and say, well, okay, well, why are we doing surveillance? What's the purpose? But these are the questions you really need to answer for yourself. And I think this might get at some of the issues about why there's so many places and countries doing NHSN surveillance, because a lot of people think it's the gold standard. But as I started off by saying, that might not be the case for your hospital. So, next slide, please. So what is HAI surveillance? Remember, HAI surveillance is a systematic collection of data on HAIs and dissemination to stakeholders, which allows a health system to estimate the burden of HAIs, evaluate the impact of prevention strategies, detect outbreaks and emerging diseases, or monitor the quality of infection control practices. So these are a lot of the reasons why you would want to do HAI surveillance. So I'm going to ask another set of questions now. And this is not, I'm not going to pick on the same people. I'm going to pick on other people, I promise. Why, for those of you that are doing HAI surveillance, or even if those of you that want to do HAI surveillance, why do you do HAI surveillance? And these are, you can look at this. This is kind of a cheat sheet, right? You can look at that as for some possible answers. But why do you do it? Why? Who wants to volunteer about why you're doing HAI surveillance? Oh, you have one. Okay. Yeah.
Sue Scott. I'm from the Children's Hospital in Melbourne, Australia. We do it firstly to reduce the morbidity and mortality in the patient, and secondly to reduce length of stay, because we've got a high turnover and we don't want to hold up those ICU beds with a preventable event.
Okay, great. So we heard you say that you do it to reduce morbidity and mortality in the patients. Surveillance by itself is obviously not impacting the morbidity and mortality of the patient. So how how do you turn surveillance into help in impacting patient care? How do you make that link? How's that link, that jump made from a chart that shows HAI rates to impacting the patients? From your experience, please.
From our experience, then it's reviewing what the preventative strategies are, auditing what we do, improving, educating, and remeasuring.
Okay. So here
and engaging the staff, engaging the unit.
Engaging the staff, engaging the unit.
Yeah.
So you heard a lot of things right here, and there's a lot to talk about with what was just said from Australia. But you heard that they take the data from the HAI surveillance and they're actually using it to inform some type of prevention strategies that they have. So they have a number of prevention strategies that are well established and that Dr. Tom will be talking about. And they use that to say, okay, we need to do this better because our rates are too high, or our rates are high in this hospital, so we need to do better in this hospital. Or maybe we're not doing a good enough job with sedation, and we need to change our sedation practices here. These are all aspects of the bundle. And we use it always to think about how this is impacting our patient care. So how many of you use surveillance? How many of you know that this is how you should be using surveillance? But really, if you're really honest with yourselves, you know that when you make your surveillance report, maybe you put it on the wall, or you write a nice report and you hand it to someone, but you're not quite sure how the surveillance is being used for any type of prevention activities. Or does everyone feel very comfortable in how it's being used? So that's a question. So how many of you are not quite sure how your data are being used? Raise your hand. Okay, thank you for being honest. This is hard. It's hard to be honest about this because I think it happens a lot. It happens a lot where we spend a lot of time doing HAI surveillance, but we don't know what happens to the data after we produce it. We spend a lot of time. We are very careful with the numbers. We're very careful with doing our data and our analysis, and we present it to the infection control committee, present it to the head of the hospital. Maybe we'll put it up on the wall, put a nice picture up on the wall, but then we kind of stop, and then what happens after that? So I think this is a critical point, really, is that if your HAI surveillance is not useful unless you actually can tie it to prevention. And I'm going to make the argument here that it's more important to spend time preventing infections and collecting some data that can inform prevention rather than collecting very good data but not having any prevention impact at all, okay? Because as I was saying earlier, one of the key limitations, the key gaps at many places in this area, it happens in the United States too, but I'm imagining it's even more so here because of my experiences and people I've spoken with, is that there's a fundamental limitation of human resources here. I think we all are nodding. We don't have as many infection control staff as we need. So that is a precious resource, and we need to use that precious resource of infection control staff in a way that most impacts patients. So when you think about if you're going to be doing surveillance, think about, well, am I using my staff time in a way that's going to be the most impactful for my patients that are here and that might be dying of HAIs? Because if I'm using all of my time collecting data but no time to prevent any infections, then maybe I need to shift my priorities a little bit. Maybe I need to spend a little bit less time collecting data but more time preventing, okay? All right. Next slide. Next one. Yeah. This one. Because remember, surveillance is a circular process. Okay, I don't know if you know this from your teaching about surveillance. Can I just, do you have to? Next. Yeah, thank you. Are they going into? No. this work? Here. Start from there. I'm just going to say next, okay? And then you both change. Okay. Because remember, surveillance is a circular process, okay? Surveillance starts off by collecting of the data, feedback and dissemination of the data, prevention informs decisions and corrective actions, and then you evaluate how those actions are impacting overall the surveillance rates. So ideally, when you're doing surveillance, data should be going in a circle, not just one way, not just collecting data and putting it on the wall or collecting data and writing a report. You should be using that data to inform your prevention actions, and then collecting data to see if those prevention actions are doing anything, and then revising your prevention actions if possible. Remember, it should be a data. It's a continuous cycle. Plan, do, study, act. Does that sound familiar to everyone? Does everyone understand that concept? Yes? Raise your hand if you don't understand that, if you've never heard that before. Okay, good. Next slide, please. Okay, so what is it specific about HAI surveillance? Well, how do you implement it successfully? There's some key pieces. HAI surveillance is sometimes very complicated. So it's important to know your case definitions and other rules. And it's important because you have to consistently apply the case definition criteria. You have to know what will meet the criteria, and so that you report those that meet them, and you exclude the ones that do not meet the criteria. And if you don't do this well and systematically, then you'll have poor quality data, and then the data will not be as useful as it could be. And if you have concerns about the criteria and the protocol, you should talk about that to the surveillance leadership, so the people who are leading the surveillance in your hospital, whether that's the infection control committee or the head of infection control in your unit, whoever's in charge. You need to address the problems at a central level so that you can discuss and identify how to make those solutions. Next one. Okay, now what's the difference between a surveillance case definition and a clinical diagnosis? We get this a lot, and in fact, we heard about it today from our colleagues from Indonesia and Vietnam also. Now, it's very important when you're talking about a surveillance case definition is that a surveillance case definition is done for surveillance, right? It's not done to identify a patient that might have an HAI. That's a clinical decision, okay? That's for the clinicians to decide. Clinicians might see a patient with a possible ventilator-associated pneumonia, and they might choose to treat that patient. But that doesn't necessarily mean that that patient meets the definition for VAE or VAP, okay? This is a very important point because remember, for surveillance, we have to use the same definition and apply it consistently. The best definitions are the ones where we do not have subjective interpretation, where the clinician is not deciding, oh, I think this looks like an infection, oh, I think this is not an infection. The best definitions are objective, okay? For clinical medicine, that's the whole art of medicine, you know? A clinician needs to think and needs to decide whether or not that patient needs to be treated or whether or not they need to have some other type of treatment. And that's a clinical diagnosis. That's not surveillance case definition. So this is a complicated point because I know in many places there's things about reporting or there's other reasons why the clinician would not want to have VAP or another type of HAI on the chart. But suffice to say, you have to separate surveillance from clinical diagnoses. Okay? Does that, I see people nodding their head, but does everyone understand that? Because this is, we hear this over and over and over again, that they're different. Because you can have a patient that has pneumonia, but they don't meet the definition, so you don't count them. But they still might be treated. The clinicians will still treat them. At the same time, you might have a patient that meets the definition for HAI, but the clinician doesn't think they're an HAI, and that's okay. There's no problem with that, okay? That's okay from the surveillance standpoint. Does everyone understand that? How many of you get some type of resistance from your clinicians because there is this tension? Yeah?
I'm Chung from Malaysia. I'm in charge of our infection control unit. So we did have some time, because we are nurses, we base on the surveillance definition. But when you go to doctors, they have their clinical diagnosis differently. So we have some argument in between. So, but then at the end, we follow clinician, clinical diagnosis.
Okay. So even though it doesn't meet the surveillance case definition, you follow the clinical diagnosis?
It met, but clinician have, doctors have different opinion on it.
So I'm curious to know, because I think many other people might have the same experience. Why do the clinicians disagree, and why do you let the clinicians, win?
We sit down together. We have a doctor from infection control. We also did have a doctors that, example, we have a VIP. So sometimes when during discussion, they disagree with it because of underlying diseases. And also, they strongly found that patient is not VAP. So we can't say anything. At the end, we follow clinician diagnosis, clinical diagnosis.
Okay. Anyone else have the same experience? Yeah.
I am from Jeradang Park Medical Center, Brunei, JCA accredited hospital. We actually, I can't say much about the surveillance of HA, VAP or VAE, because we just started including the neuro ICU and cardiac ICU under our team, just few months before. Regarding the consistency and implementation of your surveillance result or report, we started the antibiotic monitoring in the clinical side, means outpatient and inpatient. The way we did it is we spoke to individual doctors, get that concurrence, and we did with the antibiogram and a resistance pattern from microbiology department. Every month we send it to each doctor. And we monitor their prescription. Every prescription is monitored. So after 3 months, we saw the initial compliance is 58%. Now it is coming to 82%. The reason is, first we spoke to them in a nice way. Then we told them, please do it. Second time, we told them, please do it. Third time, we told them, it will affect your promotion and increments. So still you can do it. Yeah.
Thank you. Thank you for sharing. That's funny, but it's so he brings up a very important point about why we do surveillance. As I mentioned before, sometimes we do surveillance because our boss tells us we have to do surveillance. But then I think it's important to understand when you're going to be doing something that is going to impact the broader clinical community, to have some type of engagement with them too, because you can imagine if you're a car mechanic, and then someone all of a sudden says, "I'm going to start rating you about how good you do on your how well you fix cars," then you're going to want to say, "Well, okay, how can I be a part of this?" Rather than it being a report card, you want this to be an opportunity to be a way for improvement. And if clinicians, I think, many times I see clinicians will understand how surveillance can help them be a better doctor, help their patients get better outcomes, because these are all things clinicians want, of course. But if it's approached in a way, oh, we're going to report on you and how well you're doing, and you could have negative consequences from that, then all of a sudden, physicians are going to be very defensive. They're going to say, no, I'm not interested in helping you. So I think a lot of it depends on how you approach this problem, and a lot of these questions, I think, can be helped with your administration. And this speaks, I think, to a bigger point, which is around why we do surveillance and how we use the data. I think this is important because surveillance should be used for improvement, right? That's why we do surveillance. It should be used to improve practices, to improve outcomes of our patients. And in some places, we know it's being used for punishment, That's not always the most effective way of getting buy-in and getting acceptance. because, as I mentioned, if it's used for punishment, then a lot of times, as you can imagine, the first reaction you're going to get is, defensive reaction. And that's not oftentimes the best way to move forward. Sometimes it's necessary, and of course there are experiences, even in the United States, of that. But in the United States, if I ever get through my slides, it's a different experience. It's a different type of environment. Okay. Next one, please. Okay, so in the example that we were talking about, that we heard, where there's a difference between surveillance definitions and the clinical definitions, what do you do? Well, as I mentioned, despite the doctor disagreeing with having CLABSI or disagreeing with having an HAI, you should still report it because it meets the surveillance case definition. And you have to, with the surveillance case definition, you should be applying it consistently and impartially. It doesn't matter if the clinician decides it's an infection or not. They should treat it or not treat it depending on their own judgment. And the clinical judgment should not be used to overrule the reporting that meets the surveillance case definition. So remember that. And I know many of you probably say, well, it's fine for me to say that, but that doesn't happen in my hospital because the clinicians do overrule it. But remember, the best surveillance is one that's done with consistency, with a definition, and without the clinical kind of overruling that definition. Next one. Okay, so why do we do HAI surveillance? Identify the most frequent pathogens causing HAIs, determine burden and outcomes, provide a platform for measuring impact of prevention strategies, and identify potential risk factors. Next one. I think we talked about that already. So why does it have to be standardized? Well, it should describe standardized methodology and case definitions to be used across the reporting network. And the benefits are that you can combine data across hospitals as long as they're using the same protocol to calculate overall HAI rates for their network. And you can compare rates across hospitals. So how many of you think that this is important? How many of you, is it important in your hospital to compare your hospital to another hospital? Or how many of you do this routinely, where you compare your hospital to another hospital? Do any of you compare your rates? So in Indonesia, you compare your rates? Okay. Does anyone else compare your rates, or it's only internally? Yeah? Okay. You compare your rates too? Okay.
Now we are starting the national program.
Okay.
Our surveillance is only internal now. We are going to start the national program in Brunei.
Okay.
Yes.
A national program. And is it the objective, one of the objectives of the national program to compare against different hospitals? Okay. In Indonesia?
Yes, we already compare. Yes, we compare to the biggest national hospital in Indonesia.
Is it a national network?
Yes.
Oh. How many hospitals in Indonesia?
So many. But we are in government hospital, so we compare it with government hospitals.
With government hospitals.
Yes.
Okay. And so you can imagine if you have a big network like in Indonesia where you have many hospitals all in a network, you need to have the same protocol, because if you're measuring it by one way, you need to make sure it's being measured the same way, right? How many of you you're not interested in comparing, you're only interested in your own rates for your own purposes? Okay, so how many of you are doing HAI surveillance and you would like to compare to other hospitals? You're not doing it now, but you would like to compare it. A few? Yeah? Yeah? Okay. How many of you have no interest in comparing your rates at all? It's a legitimate question, because sometimes it's not worth the squeeze. Okay, so everyone would like to compare. Okay, that's interesting. There's no right answer to this question, by the way. Next one. Okay, so what are the key ingredients for HAI surveillance? Well, in order to be successful, you need, really what's most important is you need administrative support, because it's going to take time, it's going to take money, it's going to take energy, you're going to want to do something with the data. Administrative support is critical. Infection control personnel and other staff members, you need to make sure that they have sufficient time and resources. You need to make sure that you have access to diagnostics, like a microlab, and also data reporting capabilities, including Are you going to enter it on paper or computer or what? Okay. So let's talk about the U.S. Why is the U.S. How did this all start in the U.S.? So in the United States, there used to be something called NIST, the National Nosocomial Infection Surveillance System. So this was started all the way back in 1970. It was the first one that started and went all the way until 2004, mostly large hospitals. And it was very kind of old, where they had, the software was installed and they had disks, and you had to send the disks into CDC, and it was all voluntary. Facility level data was confidential. So we didn't share the data with anyone. It was all data for the hospital, for own hospital's use. And they used it to establish baseline rates and trends and assist with hospital quality improvement efforts. So it was all, while it was a national system, it was all done internally. It was only for your internal quality improvement, which was good. It led to good gains. Next one. This eventually changed to what's called the National Healthcare Safety Network. So this is a voluntary system that changed in 2005 to integrate 3 existing systems. One was NIST, the other one was around healthcare worker safety, and another one was for dialysis. Next one. So what is NHSN? NHSN is probably the most famous HAI surveillance, and it's a secure web-based system for monitoring HAI events and practices. So not just HAIs, but HAI events and practices across different types of healthcare facilities. There's a web portal to enter, analyze, and share data. And we use the data with a variety of stakeholders. So this is not just the hospital that uses the data. Many other groups use the data, including state health departments. So this is a health department that's within, that has some jurisdiction. In fact, in the United States, the state health department has a lot of the responsibility for implementing HAI programs. It's similar to like a district or a province in many of our countries. National stakeholders to check the magnitude of HAIs. So how many HAIs do we have in the United States? What type of HAIs are there? And then importantly, at the national level, we use this for payment, for financial bonus or penalties to hospitals based on performance. So this is a key change that happened in the United States, and which is why we migrated to VAE. I'm going to talk about that too. So NHSN reporting, we have 2 different types. We have infections and other. Infections are typically either central line associated BSI, CLABSIs, catheter associated UTI or CAUTIs, ventilator associated VENS, also surgical site infections, and then it's a special module aimed at multi-drug resistant organisms, including MRSA, CRE, and C. diff. Then there are other things that you can report on, including insertion practices, antimicrobial use, healthcare worker influenza vaccination, and adverse reactions to blood and blood products. Next. So in the United States, NHSN enrollment has really, really increased. And this is only as of 2015, but there are about 6,000 hospitals reporting. As of now, there are many more than that even now. And there are a few reasons as to why hospital enrollment has increased so much. So this is the whole number of acute care hospitals. So it's a very large system. Next. So why did NHSN grow so fast? Well, these are some of the key factors. So first, state health departments increased. We had an increasing role of state health departments in HAI prevention. So remember, this is not at the national level, but at the sub-national level. They had a very important part. So in 2007, there was a first state law in the United States requiring public reporting of HAIs. So this is not a national law. It was a law passed at a state level. And then in 2009, state health departments received funding from CDC to establish HAI programs in all 50 states. So CDC, at the national level, we saw that there was a need to fund the states, individual states, for HAI prevention. 2010, there was a national healthcare reform law that had many quality provisions, including all hospitals must report HAI data to NHSN to receive full insurance reimbursement. So that's called pay for reporting. So that was important because now all of a sudden the main insurer in the United States, which is called Center for Medicaid and Medicare Services, they said in order for you to get any payment, you have to report this data to this system. That was important. And then in 2013, they installed something else for bonuses and penalties for high and low performing hospitals, which is now called pay for performance. So not only was there a mandate to report, but now we're going to say, okay, we're going to use this data to, for payment. Next slide. So there's been an evolution. In 2005, the first iteration of NHSN was voluntary and confidential. In 2005, NHSN, typically participating hospitals had a full trained IPC staff, and the primary motivation was local quality improvement, was how can I make my own healthcare, my own HAI rates go down, improve my own hospital. And there was an expectation that facilities were submitting high quality data. Now this changed to the NHSN we have today, which is generally used for mandatory reporting. So it's no longer this voluntary reporting. Also today, many smaller community hospitals have limited IPC staff. But still, there's a desire to report into NHSN. And the primary motivation is really compliance with reporting requirements. So again, there's this mandate that you must report into NHSN. And because of all the issues around reporting and pay for performance, there's some uncertainty around data quality and completeness. So you can imagine now if you're a hospital executive and you start to say that my bottom line, my payment is going to be impacted by HAI reporting and by HAI rates, well then you better make sure that an HAI is an HAI, because if I'm not getting paid for that, it better be an HAI. So there is a need to make this much more objective, because you can't, so because of the new definitions must rely more on objective definitions because of this issue around performance, pay for performance. Do people understand that? This is why CDC moved from VAP to VAE. So many of you might remember the old definitions for VAP. And the primary reason why we moved from VAP to VAE is to reduce subjectivity, to increase objectivity for data quality. Do people understand that? Are there any questions about that? Because this, and so what I want to stress is that this change in definition from VAP to VAE was very much because of the US context. In the US, again, there's pay for performance. That's why we needed to have objective definitions. So when you're thinking about these definitions, and I'm going to go over the definitions in a second, when you think about these definitions, you have to think, well, how relevant is this to my situation? Is it more important that we have a definition that might be easier or might be a clinical diagnosis? Or is it really important to have these VAE events, which there are some pluses and minuses to it, as we'll talk about for the rest of the day. Does everyone understand that? Any questions so far? So I think it's very important to understand the US context, because these definitions were made for the US. They were not made with the intention that countries in Southeast Asia were going to take this. No one called anyone in Southeast Asia to say, are these okay? No, the domestic side, they don't care about anything except for the US context. Does that make sense? Now, it's not to say you can't use them, but again, it was not intended to be used outside the US. Okay. All right, so what is this thing about VAE? Let's talk about that. How much time? How much time do we have? Okay. All right, next one. Okay. Well, I think we all understand ventilator-associated pneumonia is an important complication of mechanical ventilation, right? That's why we're here. But remember, other bad things happen to people who are on ventilators, right? It's not just pneumonia. You can have fluid overload. You can have ARDS. You have all kinds of other things that happen to you when you're on a ventilator that are not necessarily infection. In fact, sometimes we can't even tell what's infection versus what's something else. Maybe it's fluid overload, maybe it's some other pulmonary condition, maybe it's a pneumonia. Sometimes we don't know. We just treat empirically and we hope that the patient gets better, right? So when you have, the problem, as I mentioned before, was that there was no valid or reliable definition for VAP. Clearly, we need better diagnostics. If we had some type of magical diagnosis by radiography or by a blood test, some type of biomarker, where you could, with good sensitivity and specificity, identify VAP, then we wouldn't need to have all these complicated definitions. But yet, we don't have those yet. So in the meantime, how do we make the definition better? And this was, again, something that we went through in the US. So the commonly used definitions all included subjective elements and were neither sensitive nor specific for VAP. There was some data that showed this. And then, again, as I mentioned, in the US, in an era of public reporting for HAIs, and where there is the need to compare across facilities and for pay for performance, we needed a new approach. We needed to come up with something that was objective and that was repeatable so that you can compare across institutions. Again, this might not be the case in your country, in your hospitals, but this was what happened in the US. Okay, next. Okay, so remember the old VAP definitions? Those VAP definitions all use combinations of criteria that were subjective and subject to bias. So, chest x-ray, clinical signs and symptoms, microbiological evidence. Next one. Yeah, next one. So in chest x-ray, there's lack of specificity. There's a lot of data showing that there was inter-observer variability. What one person said was a pneumonia, another person said was not a pneumonia. And also, this was also not within the purview of the infection preventionist expertise. So it was we were relying upon a radiographer to interpret it. It wasn't something that an infection control nurse or practitioner could read and objectively come up with a definition. Okay, next one. Clinical signs and symptoms, I think we all know they lack sensitivity and specificity, especially if someone on a ventilator. It's very hard to find out what they're complaining about. They're highly subjective. And if you're trying to rely on the medical record, the documentation oftentimes is not there because the charting was poor. Next one. And then microbiological evidence. Even in the best case scenario, it lacks sensitivity and specificity. Practices vary among practitioners. I think maybe a lot of you can understand that. We don't always obtain a culture or always obtain a good culture for ventilator-associated condition. And then there's also some controversy about some of the best practices around that. Okay, next. All right, so what were the goals? We wanted to achieve validity and clinical credibility. Sorry, keep going. We want to improve reliability and also reduce the burden. When I mean burden, reduce the burden on people who are collecting the data. Okay, so what are VAEs then? So people understood that we had to move from ventilator-associated pneumonia to something that was more objective, and we called them ventilator-associated events. So a ventilator-associated event is not necessarily a ventilator-associated pneumonia, okay? A ventilator-associated event is some bad thing that happens to you when you're on a ventilator, okay? So sometimes it's pneumonia, sometimes it's not, sometimes it's lung injury. But there's all these things that take into account. It's something bad that happens to you on a ventilator. So there are basically 3 different tiers. There's tiers 1 and 2, which are essentially ventilator-associated condition and infection-related complications. So VAC and IVAC. And I'll talk about the definitions of what they are. And then tier 3 is something that's called VAP, which is kind of what we're used to hearing, which is not just there's evidence of infection, but there's also microbiological evidence. So, and I've got another slide because I think this is where most people get confused. Is what is the difference between all these definitions? Next one. So who's eligible for VAE surveillance? So we'll hear about pediatric, but for adult VAE, you have to be greater than or equal to 18 years of age. You have to be in an acute care hospital or long-term acute care hospitals or a rehab facility. And then it's people who are on high-frequency ventilation and extracorporeal life support, so that's called ECMO, are excluded. So it's really on people who are on conventional ventilators. And the way, go back, yeah, that's fine. And the way to think about VAEs is that, as I mentioned, VAEs are any kind of bad event that happens. So it consists of 3 different conditions, really. So there's ventilator-associated condition, which that's your kind of first tier. Then infection-related ventilator-associated complication, that's your second tier. And then the third tier is called PVAP, which is basically, or VAP, which is a possible or probable ventilator-associated pneumonia. So it's basically, the way you have these is that a VAC, which is, again, the tier 1, is based on changes in PEEP or FiO2. So these are parameters on the ventilator that are objective that you can see. IVAC is essentially a VAC with evidence of infection, okay? And then PVAP is an IVAC with evidence of pneumonia. So you can see that each one has a higher degree of criteria. So again, start off. VAC is basically these are all VAEs. So VAC is a change in PEEP or FiO2, and I'll go into the definition of what that is. But that's not as important. It's just understanding that you're looking at the ventilator settings and the ventilator and the outputs and seeing, is there a change in PEEP or FiO2 that warrants the definition of a VAE? Then infection-related ventilator-associated complication, or IVAC, where you have VAC plus some type of infection evidence, and then PVAP, which is evidence, which is an IVAC with evidence of pneumonia. Okay? Okay? So it's not that complicated, actually, when you break it down like this. It does get complicated when you're applying the definitions, but this is the basics. Okay? Does everyone understand that? Yeah? Is it easier to think about it like this? Yeah? What's that? Yeah? Okay, well, I'll talk about that. I'll talk about why it's different. Okay. Okay, next one. Okay, so tier 1. And I don't think you need to memorize this, okay? It's in your notes. I'll show you where on the website to look at it. It's not important to memorize the exact definition now. What's important is to get the concept, okay? So VAC is essentially you have a patient who's doing okay, and then all of a sudden they get worse. Their lungs get worse, okay? That's the important thing to think about, is that I've got a patient who's on a ventilator that's now doing worse. And I can tell they're doing worse because they have an increase in your daily FiO2 of 0.2, sustained for greater than or equal to 2 calendar days, or an increase in daily minimum PEEP of greater than or equal to 3 centimeters of water over the daily minimum PEEP, sustained for greater than or equal to 2 calendar days. Okay, so these are the definitions. You don't have to memorize the definitions, but the concept I want you to come away with is to meet the tier 1 definition, you have to have some evidence that your lung function is stable, and then all of a sudden it's getting worse, okay? It can't just be, someone who's admitted and they're getting worse and worse, and their lung function is getting worse and worse, and they were never stable to begin with. That would not qualify. So they first need to be stable on the ventilator and then get worse, okay? If they're admitted to the hospital and they've got terrible sepsis and pneumonia and they're just getting worse and worse and worse day by day, that doesn't qualify, okay? They have to be stable at first, 2 days, and then getting worse, okay? That's the first tier. And then the way you judge that, whether they're getting worse, is by FiO2 and PEEP. Okay? Next one. Okay, so now everyone understands, okay, VAC, I get that. Now what about IVAC? Remember, that's a VAC where you have some evidence of infection. So what does that mean? It just means that if you have a patient that meets the criteria for VAC, then you have both of these both of these present. So you have a fever, either hyperthermia or hypothermia, or a white cell count above 12,000 or below 4,000, okay? And a new antimicrobial agent is started. Okay. So treatment and some type of clinical sign or lab value that is suggestive of sepsis, okay? Does that make sense? And then that meets the criteria for IVAC. That's infection-related ventilator-associated condition. So it's not, you can imagine, I'm thinking, there are plenty of patients that meet this. It's not very specific for an infection, but it's infection-related, okay? The next one is more specific for infection. Because in the next tier, you have culture evidence. Okay? Good? Questions?
Do you include CRP protein along with white cell?
I do not believe that CRP is included in the definition.
Do you think that it's essential to correlate
CRP?
along with the
I think that the important thing for when developing definitions are to make them as reliable and simple as possible. There's always a trade-off between sensitivity and specificity. I think that honestly, you could create a very solid, specific definition that no one's going to argue with, that this person has pneumonia. But the cost of doing that is that it's going to be hard to replicate it in other situations. So I think there are additional criteria, and I wasn't involved with the creation of these criteria, but there were other criteria that they looked at. But there was consensus that these criteria were the ones that were most readily available. Because remember, one of the things that they were trying to address is that in many places, even in the United States, many places, some diagnostics were not being obtained routinely, okay? But everyone who's on a ventilator has these parameters, and everyone who's on a ventilator can tell if there's a change in FiO2 or PEEP. Okay, next one. Okay, and then I think I forgot to add the next slide, but so tier 3, remember, is IVAC plus evidence of microbiology. So that's when you have a culture or a lung biopsy that shows bacteria or some type of organism. So you have IVAC, which is again, remember, someone who has some evidence of sepsis and treated for sepsis, and then you have VAP or PVAP, which is possible ventilator-associated pneumonia, where you have a culture or histopathology of an organism. Does that make sense? So again, 3 tiers. The first one is just showing something that